am very pleased to announce you my 6-month progress, which I have made since I've become the Translational Medicine PhD student. I am investigating a very exciting topic, I think, because I am working with the role of left atrial strain in neurocardiology. My name is Henriette Mészáros, and I work at the Heart and Vascular Centre of Semmelweis University as a PhD student and a cardiology fellow. I can see in my everyday practice that the detection of atrial fibrillation requires expensive, prolonged monitoring, so that is why derives my mission to decrease the necessity of prolonged monitoring with the help of my study. As a quick overview, I would like to introduce you that I am working on 2 projects currently. The one is in which we are investigating the association of left atrial strain and the occurrence of atrial fibrillation. And on the ground of this project, we are planning to submit a protocol of a single-center randomized trial. We are aiming to investigate the effect of high versus low mesh density device on atrial strain in patients with patent foramen ovale. So first, let me speak about my first project. As a quick background review, I would like to highlight some information. Old age, as we all know, comes with comorbidities. For example, in cardiology, left ventricular dysfunction plays the main role. It can lead to left atrial remodeling, to the so-called atriopathy, which can result in atrial fibrillation. While atrial fibrillation is present, there can be stasis in the left atrium, and mainly in the left atrial appendage, it leads to thrombus formation, which can result in cardioembolic stroke. Nowadays, the only and gold standard method of diagnosing atrial fibrillation is prolonged ECG monitoring. But it's, as we know, it's very expensive, and there is no consensus on the appropriate modality and duration. So therefore derives the idea that we should use a novel, sensitive and non-invasive model which could assess the left atrial remodeling. This is the so-called left atrial strain analysis, which could predict the occurrence of atrial fibrillation. So basically, our aim is to limit the range of patients who need prolonged ECG monitoring. Here you can see my clinical question: is the decreased left atrial strain associated with the occurrence of atrial fibrillation? We aim to investigate patients from cardiology departments who had on 2-dimensional speckle tracking echocardiography exam left atrial strain analysis, and we compared patients who were detected with atrial fibrillation during follow-up and who weren't detected with it. We assessed as outcomes left atrial strain parameters. And our hypothesis was that patients with atrial fibrillation have decreased atrial strain. Here you can see the flowchart of my selection. At the end of the process, I had 5 eligible full text which I could use. So let me speak about my results. My first outcome was a global longitudinal atrial strain. Basically, it describes the function of the whole left atrium, so it contains all the segments. As I mentioned, I had 5 eligible full text, and we were working with mean difference data. And as you can see, I had a quite high heterogeneity, which derives from various factors, which I would like to highlight by the limitations. But as you can see, at the end, we got also statistically and clinically significant difference between the 2 groups, the ones who haven't developed atrial fibrillation and the ones who developed. And after it, we excluded 1 study from the analysis because it was a retrospective study, and we would like to see if there are only prospective studies, is there still a significant difference? And we found that yes, it still remains a significant difference between the 2 groups with a high heterogeneity as well. After it, we analyzed the left atrial contraction strain rate. It's most important strain parameter for the connection of left atrium and atrial fibrillation, because during atrial fibrillation there is no contraction in the left atrium. And here we found also a statistically and clinically significant difference between the 2 groups. So atrial fibrillating patients had a significantly reduced left atrial strain. After it, we did also, only with the inclusion of prospective data, this analysis, and we also get here significant data with a lower heterogeneity. And let me speak about now about the strengths and limitations. The main strengths, I think, is that it's a very novel and hot topic, and because there are thousands of people who have silent atrial fibrillation in Europe, so it has to be it needs further research. And I think that despite low number of studies, there were many patients included in the analysis. But I also have to speak about huge limitations, because one of it is that there was no uniform data reporting, because there were different monitoring methods used for atrial fibrillation detection. Like in one study they used only 24-hour Holter monitoring, in another study they used 13 days Holter monitoring, in another only symptom-based monitoring, so it was a limitation. And I have to also mention age heterogeneity between the studies, and the fact that it is known that left atrial strain decrease also physiologically with the age, and also with comorbidities, so it was also a limitation. And yes, we had low number of studies because it is a novel topic. So let me summarize the implications for practice and for research, because both is very important and they are in a close connection with each other. So the first, for the practice, we could select patients who need prolonged heart rhythm monitoring and who need anticoagulation immediately with the help of these parameters. And also there is a huge implication for research, because for this to predict in the practice patients who need this monitoring, we have to define first cutoff values, because only this can be this can provide sufficient data for us. As a conclusion, I can say that there are significantly reduced left atrial strain parameters in those who developed during follow-up atrial fibrillation. Now let me speak about quickly my second project. It is, as I mentioned, the two-arm randomized non-blinded trial. We are investigating patients over 18 years who were referred to PFO closure due to characterogenic stroke, and we would like to compare patients who got a high mesh density device during the closure with patients who get low mesh density devices regarding change in left atrial strain parameters as a primary outcome, and regarding atrial fibrillation as a secondary outcome. And our hypothesis is that PFO closure with low mesh density device is non-inferior to PFO closure with high mesh density device. And of course, we have a clinical and research implication. We would like to decrease the postoperative atrial fibrillation. Here you can see the two arms which I already mentioned, and we are also planning to have a control group with patients who were not eligible for some reason for PFO closure. And as a primary outcome, we defined changes in left atrial strain and strain rate parameters, and as two main secondary outcomes, I would like to highlight atrial fibrillation and recurrent stroke. So what about next? My aims are to plan to submit the first paper in May 2022 and the second in July 2022. I would like to thank you for your attention with my favorite quote. I believe that today is your opportunity to build the tomorrow you want.
And congratulations, of course, important studies. Actually, you kind of answered my questions in your implication for research, that of course you need cutoff values for that method to be predictive enough to say that, look, this patient will for sure, can I say that for sure they will have atrial fibrillation in a couple of months, yes, years, so they have a high probability that...
only with individual patient data we could not say that, so further prospective studies are also needed. So in the case if we had these individual patient data, we could not make a huge cutoff value determining. So
Yeah, also my question is related to that, because I was thinking what to ask about this, how to go further with this, sorry, not about the question. Yeah. So you are saying that you have statistical significant results, but actually is a -2 clinically different, or is that is that a statistical difference, or sorry, I was following you, but I did not catch if there is also some kind of other changes, or is this also correlated with other cardiological parameters?
Thank you for the question. It's also statistically and clinically significant, and it's a minus value, yes, but because in patients who develop later atrial fibrillation during follow-up, their atrial strain decreased, so that is why it's a minus value.
Nice study, and as not a clinician, I may ask not appropriate question, but how did you define atrial fibrillation, paroxysmal versus chronic? Do you have differences if the atrial fibrillation is different in terms of chronic or
in these studies?
Yeah.
That was the main limitation, that they were differing. So in some studies they already used they already defined atrial fibrillation by one ECG, and in another only by already with a Holter ECG. So it was very various in these studies. So it wasn't clear always if the patients had only paroxysms or persistent or so.
When we talk about this cutoff, I'm absolutely outsider on this. So it's always hard to give a cutoff, because you will get then false positive, false negative, whatever. Did you consider actually to give ranges?
Yes.
And then say that this is the probability of this range, because it may be better than giving just one value?
Thank you. Thank you. It's a very great idea, because we already talked about it, that regarding this clinical question whether someone should be anticoagulated or not, it's not okay to use only one value, so we have to think about in ranges. We think it as well.
Thank you for this nice presentation. I have two questions. The first one is, are there any different left atrial parameters which are associated with atrial fibrillation occurrence? Maybe in the everyday clinical practice more easy to measure than a strain. And my second question is, in a clinical situation, how do you decide if you implant a low density or a high density mesh device?
Penny, you got 15 seconds, 10 seconds to answer.
Okay,
but take your time.
For the first, you mean not strain parameters, but other parameters. So the E per A parameters, so when A is not present, then it is atrial fibrillation. And the left atrial volume index, if it is bigger, then it is a higher chance to develop in a large dilated atrium atrial fibrillation. And also maybe the TDI values, I think they can be also promising tools. And I think this is for the first. And for the second question, it is a great question. We are planning. Now we don't know that one is better or the other one, but in patients with higher PFO channel, we have to implant a higher mesh density device, because it closes better the tunnel. But if someone, maybe the strain parameters later in the future could predict also preoperatively which one will have a higher chance to develop atrial fibrillation in the future. And for those, we would like to recommend implanting lower mesh density devices.